We're good. Well, good afternoon, everyone. Thank you so much for joining us for sort of our next installment of our Centering the Margin series. For today's event, we're really commemorating Black Nurses Day that was celebrated earlier this month and part of Black History Month as well. And this is, again, is a speaker series sponsored by the DIO. I am Jorge Sanchez. I am the program director of diversity and inclusion for Health Consulting, and also a member of the Diversity and Inclusion Office and co-lead of this particular series. So along with Dr. Jules Troba. So we're very excited for you to join us today, as we often do when we bring our larger community together. It's an optimal time to just reiterate and reinforce that UMass Chan Medical School acknowledges that its campus is located on the lands that were once part of the original homeland of the Nipmuc people. We denounce the violence that stripped these original stewards of lands that were their ancestral home and denied their descendants the opportunity for an authentic connection to it. In making this acknowledgement, we announce our intention to listen to and follow the lead of our Indigenous neighbors and work together to create new legacies of equity and respect. And for those of us who have joined us for the first time, the Centering the Margin series was really developed and designed to lift the voices and stories of diverse communities that we traditionally are marginalized, and provide us an opportunity and a space to focus on the unique perspectives related to the experience of diverse communities, and create, again, a space and community where we can discuss and bond and celebrate those unique needs, concerns, and associated with the intersections of identity, which is really the focus of this particular series this winter, in terms of intersectionality, which is the interconnected nature of the social categorizations such as race, class, and gender, as they apply to a given group or individual, regarded as creating overlapping and interdependent systems of discrimination or disadvantage. So as we think about the stories that we're hearing today, personal journeys and work, it really is around a systems framework and how do our folks' intersectional identities, how we encounter the healthcare system, both from an employee, employer, and potential patient experience. What does that look like and mean for individuals in the health systems? And as we think about these stories and experiences, how do we keep that in mind when we think about dismantling the oppression within the systems that we work and inform? So as we start and embark on our conversation, I'm going to toss it over to Dr. Jules Troba, my co-lead in the series, to get us going.
Thank you. So because these can be sensitive conversations, we always start with a community agreement where we want to be engaged and be supportive of sharing ideas and spaces, be respectful to yourself as well as others with unique lived experiences, be bold but be humble, be accountable to both your intentions and the impacts of your words on others. Approach any controversy with civility, be mindful and uphold confidentiality where appropriate, autonomy to choose when to join or leave the conversation, and of course, no attacking or causing intentional harm. Would anyone have any additional agreement that they want to add to this list? And by the way, we will use the meeting chat. I have the meeting chat open. So if you don't want to speak out loud, you can always put it in the chat. But hearing none, we can move to the next slide. So today, we're going to have Dr. Danielle Larkin talk to it, or be our moderator for our panelists. Unfortunately, Dr. Rita Amoa is not feeling well, so she won't be able to make it. But Dr. Akwasi Dua and Dr. Rose Krunzi Sima are also our panelists today, and they'll be all three of them will talk about their personal experiences. And then at the end, we're going to hear from Andrea Bresnahan, who's the executive director for the Nursing Council on Workforce Sustainability at For Health Consulting at UMass Chan Medical School. So Dr. Danielle Larkin graduated from Goucher College with a BA, and then she went to National University and received a Bachelor's of Science in Nursing. At the University of Alabama in Birmingham, she received her doctorate in nursing practice. She's worked in gynecology, oncology, infection control. At Auburn University, she became an assistant clinical professor. She's also worked as a nurse practitioner in palliative care and a nurse practitioner in general. And now she's an assistant professor of clinical track at Emory University's Nell Hodgson Woodruff School of Nursing. She has won many awards and has several publications as well as grants in nursing and nursing education. So I want to take this time to welcome Dr. Danielle Larkin.
Great. Thank you so much, Dr. Troboff, for this introduction. And I just want to say thank you all for being here and taking the time to spend a little part of your day with us to hear our stories and just learn about us and everything. But I just want to kind of start this off and just, I'm sure you're aware, but the registered nursing, like many other health professionals, it's not as racially and ethnically diverse as the country's population. According to the most recent Census Bureau, roughly 76% of the US population identifies as white, and 13.5% of the population identify as Black or African American. The National Council of the State Boards of Nursing conducted a survey in 2020, and they collected a ton of data. And from their research, they noted that 80.6% of the nursing workforce is white versus 6.7% of the nursing workforce, which is actually, it's increased from 2017, but 6.7% of the nursing workforce identifies as Black or African American. So as you can see already, there is a disparity in amongst the diversity with nurses as it relates to the United States. While nursing has long recognized and promoted culturally competent nursing care, we really haven't focused on the actual diversity within nursing itself and the people that are actually providing the care. I will also state that the research is out there that it is the African American nurses and people of color that are actually obtaining higher degrees in nursing. From the data that I looked at, it was the most recent data that I found, unfortunately, it was from 2008. But the 2008 National Sample Survey of RNs, which was conducted by the U.S. Health and Resources and Service Administration, highlights that only 48.4% of white nurses complete nursing degrees beyond the associate's degree level versus Black or African American nurses, that's 52.5% have degrees higher than associate's level, which I think is really profound. And, you know, it takes me back to my childhood when, you know, my parents would always talk about this, and my grandparents, and, you know, my grandfather was actually a civil rights lawyer. And he, you know, we were always raised with the mantra of, you have to do as much, if not more, than your counterparts to be seen as equal. So I think that's probably where a lot of African Americans kind of grew up with that in their mantras that was repeated constantly. And I think that's probably one of the main reasons why more African Americans and Blacks have gotten advanced degrees in nursing as opposed to white counterparts, because we always felt like there's something to prove. And with nursing, really the only way you can prove it, other than outstanding nursing care, which is subjective for a lot of companies and places, is having those degrees. Like I call it my alphabet soup behind my name, and that to me, it demonstrates my proficiency and my dedication to this profession. So with that being said, I feel like I have a really interesting and unique perspective when it comes to nursing as a nursing student, as a bedside nurse, as an advanced practice nurse, and now as faculty, because now I've seen it in so many different ways. So I'm really excited to share my story. One of the reasons I think a lot of African Americans and people of color are getting into nursing is now there's actually more ways to actually become a nurse. Before, we only had those traditional programs, and now we're seeing these pathway programs where someone could get an associate's and bridge to a bachelor's, or there's now master's entry nursing programs. So I myself was a non-traditional student, meaning that, I did have a previous degree. I did go back to school when I was older. So I didn't fit into that, traditional BSN paradigm. But I will say that I did appreciate going to school a little bit older, and I just wish that I had the knowledge now that I didn't have then. But hindsight is always 2020. And I can tell you one of my whys is why I knew I belonged in nursing. It was during one of our first clinical rotations, and I had this elderly African-American patient that unfortunately had diabetes. He was also developmentally delayed. And so when it came to see his wound dressing, again, this is one of my first clinical interactions with a clinical setting. And so my nursing preceptor said, oh, this gentleman is getting his, he unfortunately had his toes amputated because of his diabetes. So they suggested that I go see his wound change. So, the first wound change is always done by the surgeon and usually a fellow. And so I went in, and again, this gentleman, very sweet guy, but developmentally delayed. These two white doctors were making fun of him to his face. And he didn't really understand what they were talking about. He was just kind of laughing and going along with it. And I just stood there paralyzed. And I just kept thinking, how can I be a person of color and they're making fun of this person of color in front of me? And I just thought that was so bold. And, it's like, I felt at that point, I knew I was hyper visible, but I felt so invisible at that time. And it was just shocking how, the privilege that they felt that they had. And, I don't know if it was, I can't explain why it happened, but at that point I knew the healthcare system needed more people of color to help with these situations. So again, I wish I had been further along in my nursing career and had felt empowered to speak up and say that wasn't right. I literally was paralyzed when that happened. So again, that was kind of one of my whys as to why I feel like I truly belong in healthcare. As a bedside nurse, I know a lot of us are bedside nurses. We deal with things day in and day out. One of probably my most vivid stories that I will never forget, of course, if you're going to get an admission, it's going to be at 1, 2 o'clock in the morning, right? You're never going to get those admissions at an ideal time. But I got an admission and kind of similar case where, diagnosis, guy was diabetic and had this, he was homeless and diabetic and had this unhealed wound on his foot that was just getting really infected. So of course they admitted him to the hospital. I was in charge of taking care of him. And I don't know if a lot of people have dealt with homeless people, and I respect their property because I know that's really all they have. However, this patient had tons and tons and tons of insulin at the bedside, as well as gabapentin. And we know gabapentin, if you take too much, can be very sedating. And of course, it's easy for someone to overdose on insulin if they take too much, and that can cause anoxic brain damage. So the policy at the hospital that I worked at was absolutely no medications at the bedside. So I tried to explain to the patient that, this is just normal policy and procedure. I'm sorry, I do have to take your meds, but I will come in with a charge nurse. We will count everything in front of you. We'll sign a form. I will usher this down to pharmacy to hold it and protect it from, from you, from everybody, from someone coming in and taking it. We just can't have the meds at the bedside. At that point, this gentleman, he was Caucasian, tried to lunge at me, hit me, was starting to call me all sorts of nasty names, accusing me of being a drug addict, telling me I'm just trying to steal his meds. And it was a really horrible experience for me, but he was my patient and my job was to care for him. And I didn't know what to do, but we had called the doctors and let the doctors know of the situation. They had told me, well, can he just keep his medication at the bedside until we figure it out? And I just kept saying, well, I don't want to break policy and procedure, because if he does something, what leg do I have to stand on in court? Like I have to follow policy and procedure. So there was really no work away around, about that, but I just did what I had to do. And I ended up just taking his meds to pharmacy and we did that. But again, he was so rude, so mean, calling me nasty racial names throughout the remainder of the shift. And so I requested from the charge nurse to please, can I have another patient assigned to me? And for my next shift, because I was there for the next 2 days. Well, I kindly request that from the charge nurse. And when the nurse and the charge nurse was fully aware of the whole situation. Well, we only had one other African-American nurse working the morning shift, and she gave that patient to the only African-American nurse on that shift. And I was just kind of stunned after she knew what had happened to me and how he felt towards me. And then honestly, for the next 2 shifts, I had him and I only handed him off to either another Black or African-American nurse or a Jewish nurse. And they felt this exact same way I did, with the name calling but we had to do what we have to do because he's our patient and we have to care for him. So when I approached my nurse manager about this, I was just told, well, you just don't need to go to the room. Don't go into his room. And I said, well, I'm caring for him for 12 hours. I have to go into the room at least once an hour. That's guidelines, our hourly rounding. And that would be neglect if I didn't. But that's what my charge nurse told me to do. And I just said, I will have to just suffer through it and put up with it, because I cannot neglect my patient, even though this patient makes me feel horrible, makes me feel uncomfortable. This is my role. And then another time with a completely different scenario, when I first got into oncology, I remember helping a patient that was about to go home on home hospice, but he needed help to the restroom. And of course, I'm going to help ambulate my patient. Safety is one of our primary concerns. But we all know how fashionable these hospital gowns are, right? So I help him out the restroom, or help him to get out the bed to go to the restroom, and his gown in the back comes apart. And I see a back full of swastika tattoos. And I froze for a second. But I continued walking him and made sure he was safe. I treated him as he was my own family, because that's what we have to do. And I've never seen it the reverse. Like I've never had a colleague that was Caucasian or white complaining that the Black patients don't care for them. It's something that I never see, but it's just stories like this, like mine, that I hear repeatedly over and over again. But regardless of what happens, my job is to care for these patients. As a nurse practitioner, I have had the best experiences trying to change people's mindset, especially African Americans and Blacks' mindsets when it comes to the healthcare system. And I love that I can be that model for them. I will tell you, I work as a palliative care nurse practitioner in Auburn, Opelika, Alabama still, even though I live in Atlanta, I still work there. And it's what, 7 or 8 miles from where the Tuskegee syphilis study happened. And so there's still a whole lot of mistrust in that, especially that region. And I think throughout the United States, but especially in Alabama, but specifically in that Tuskegee, Opelika, Auburn area, huge mistrust of healthcare. So I love that I can come into an African-American or a Black patient's house and be articulate. I can tell them what they need to know. I can help support them, you know. So I love that I am that, you know, that for them. And then as far as being a nurse faculty, you know, I love that, again, I can be that nurse faculty member that not only Black students look up to as, you know, she is a doctorate. She has alphabet soup behind her name. She's published. She presents around the world. Like she's all of this, but I can also be representative for those of the white, you know, white community there, showing that Blacks we can be just as equal as our white faculty members. So I love that I get to represent so much for these students. So that's kind of my story in a nutshell. So I will hand it over to Dr. Does Dr. Dewey want to go next? Or
Oh, okay. Thank you, Danielle. That was a very, these are very powerful stories, you know, and as we know, stories are powerful and also used to change perspectives, you know, so thank you. For me, nursing is a second degree. Originally, I'm from Ghana, Africa. So, you know, right from the start, you know that I have the British accent. So the way I speak may not be the same as the way an American speaks. So that is also a very big hindrance for me, especially, you know, being in America, you know. So going through nursing school for me was very exciting, was very educative, and was very positive, you know, because I went in there for the quest of knowledge. And anything that I encountered from my colleagues, you know, from my peers, from my professors, I see it more like a push for me to get better, you know, and to improve on myself, you know. But I began to experience what real racism and also what is it like to be different when I became a nurse, you know. And I think I can share many stories over here, but one thing that is very important to me that I want to share is a quote by one of our finest in Africa. She's called Dr. Ngozi. So she said that you know what, we all have misconceptions about each other, you know, and it's true. And I think it is about time we all accept that we all have misconception about each other. But she also said that most of the times we don't understand the full story. All right. So we don't understand the full story because we are not able to communicate with each other, you know, and that is very, very important in the story that I'm about to share, you know, because for me, you know, I mean, right after nursing school, you know, I was actually working at a place, and I experienced what we call nurses EDI young, you know, early. And especially being Black and being male, you know, it wasn't advantage for me. So there was this colleague, a white colleague, who always looked down on me because of the way I look and the way I speak, and can be very disrespectful, you know, to me even in front of patients, you know, which used to bother me a lot. But at times, I mean, there is this fear as a Black nurse for you to speak up, you know, because number one, you are new and you are a new grad, you know, and you are always sailing on the wings of others. So how do you balance the ability to speak, you know, civilly and not being misunderstood, you know? So for me, that was very huge, you know. But one day I'm like, you know what, enough is enough. So I'm like, hey, we really have to talk, you know. And the summary of my conversation was like, you know what you know, I also know. I'm not inferior, you know. And you know, it didn't stop per se, you know. I mean, it went on for some time, but gradually it came down a little bit based on the fact of what Danielle said, previously, because as a nurse, you always, especially as a Black nurse, you always have to prove yourself, So I have to put in that work, do that extra job that my colleague Caucasian nurse wouldn't do, and as time goes on, she began to accept the fact that, what she knows, I also know, and I wasn't inferior, So many stories relating to patient encounter, but for me, such as I said, using stories to change perspectives, is very, very important. And there were many negative, patient encounters, but I see the learning opportunity that lies in such a challenge. That is how I see such an encounter. I used to work on a psychiatric unit, and one day, and I'm sorry, is it okay if I quote what the patient said, or I can't, but I think it's very important to quote so that we will begin to be more aware of what we experience as Black nurses. This patient came in very psychotic, and unfortunately, or fortunately, I was a nurse, and she was about middle-aged Caucasian lady. And during the course of care, as soon as she saw me, she just didn't want me to be the nurse, but we really have to communicate and for me, make patient aware that I am here for you. All right. But for some reason, I think it's just she wasn't having it that day, and it just came straight to me in the middle of the milieu, saying, Akwazi, if this was in the 70s, I would have hung you upside down. And I'm like, oh, but even though it was very shocking, I didn't say anything, because one thing about nursing is that, and one thing that drew me to nursing was the belief in multiple perspectives. There is not a truth. There is not their truth. There's a truth. And unfortunately, at that point, something was masking her truth. So what can I do as a nurse, to provide that form of education? And to me, I thought it was very important to just be silent. And Danielle and Rose Dr. Rose can testify the fact that anytime such happens and the nurse becomes very silent, I would say that all the time, or I would say 90% of the time, patients themselves, whenever they become much more sober, in quote, they come back and apologize, and I think that is a moment, for us, that is a teaching moment to, to do a form of teaching per se. So I what do I have to say again, Daniel? I think there are many stories to share, and there are many things to say, but one thing that is very, very important is that all these experiences have built me up as a nurse educator, and because I understand my students better, either like Black or white, and especially having students who look like me coming over and being able to see where I am right now, and also me being able to share some of the challenges that I encountered, actually provide some form of hope. I think as a discipline, as a society, we have a long way to go. We have made some positive strides, but we do have a long way to go. And one of the best solution or the method that we can forge ahead is being able to communicate with each other and talk. And once again, as Dr. Ngozi said, let's accept the fact that we all have misconceptions about each other, historical facts, or whatever form that it may be, but I think it's about time that we communicate.
Great. Thank you so much. I appreciate that. And I definitely want to talk about storytelling a little bit later. So we'll put a pin in that. Dr. Karanza Sime, do you mind sharing your story, please?
Hi, everyone. Thank you for having me. And just like Dr. Dua said, I I'm originally from Ghana as well. And the big one is the accent. The accent was my #1 welcome to America deal. So I got to the airport and I'm speaking. I thought I was speaking English, but I was told, can you speak English? So that was my first shock when I came to the United States. So that lives at the back of my mind. But my journey on like the Neil and Crisis journey, I came to the United States. I wasn't a regular average student or undergraduate. But I started school. When I came, I thought I would be able to just go to nursing because I was in nursing school when I won the visa, the green card lottery. I'm like, yay, I can go to the US and become a nurse. Unfortunately, like I didn't come with transcript. All that I had was my certificate and later that I was in nursing school. So I thought I could just get in, but that wasn't the issue. That wasn't the process. So I had to start the whole process again. I had to take English as a second language, although, Ghana was colonized by the British. And I'm like, I've spoken English all my life, but that wasn't enough. But at the back of, sometimes I'm grateful for taking that class because there's just a little bit, few words in the British that is, that is a little bit different from American English, but I still did that. So that's one of my strong stories that I used to encourage my international students or people who have come, like, don't let that stop you. You can still go. So that that was the beginning of mine. And I wasn't able to get into the nursing in the community college because it was very competitive and they take a certain number. So I ended up, one of my friends, bless her heart, told me, let's go to Howard. So it was a long journey. We had to drive ourselves. So I got into Howard and DC, and it was an exciting journey. So I had my BSN, and honestly, all that I wanted to do, I've always wanted to be a nurse. So that was all that I was looking forward. Let me just be a nurse. And so when I was about to graduate, I'm like, what if I wanted to do something? So now let me get some good grades. Yeah, right. So that was it. And I started working, and just like what they all said, my why was, I've always wanted to be a nurse. But so during the time that I was doing my prerequisite to go in, I was working as a CNA. And just like Daniel's story, this story is I get a bit emotional each time I want to share. I was a CNA, it was a young African-American lady who passed away on my floor. She was kind of usually, and we all know, we call them she's a frequent flyer, but she has sickle cell. So every time she has sickle cell crisis, she was on our floor. And the pain medication, sort of like drug seeking, blah, 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 but nobody can, understand sickle cell crisis because they are in pain, they are dehydrated. There's so many things, but the care was not there. So the last time she came, she had gone to the bathroom. So when she called, I ran to go get her. And when I got her, she has passed out on the floor. So I called, when I called, we went from, we didn't have rapid response and it was cold. And by the time everybody came, she had passed out. She passed away in the bathroom. And at that point, I'm like, could we have done something more? But I was a CNA. What more do I know? And what more can I say? So that was one of my whys that, I should be able, now that I know the facts, if there's anything I can question somebody, what kind of, what is the care? What are we doing for this patient? So that was my my experience. So when I became a nurse, just like what everyone else has said, when I started out, it was, you get a protective assignment when you get off orientation. That didn't happen. So on a message floor, you get all these patients and you have to care for them. So I got one, and my story was I went in, and every time, you notice a pattern of the assignments that when you come in, and literally I am the only, African or, African-American on the floor. And then you come in, you get all the cases that are in that corner that nobody else wants, or they give you that. So on that day, I went into a room and my patient was, not having it. I walked in, the family was there. And then I was so excited. Hi, my name is Rose. I'll be your nurse for today. And after I said all my spiels, he went out and told me, get out of my room, nigger. Go to where you belong. And I mean, like, I froze for a minute, and then I'm like, get it together, Rose. So I said, okay. So I put it back together, and you can see the family was just like, they could quell, like, you know, everybody in there was like, oh my God. So I said, and I addressed him, I said, this nigger happens to have a name. My name is Rose, and you are my patient, and I'm here today to care for you. So unfortunately, you have to deal with me today because I'm here to care for you. And he was like, I'm not going to do that. I'm like, we're going to do that. So I mean, this is my first run. I'll come back and then I'll take care of you. So when I left, the family, one of the family members ran out and told us like, it's not your fault. It's okay. We'll do this. So I went back and I told my charge nurse, not knowing I think it had happened before, but still they did not, you know. So I was like, okay, we'll take care of that. And so I gathered my stuff and I went in with my CNA. We took care of this patient, and he ended up requesting me every time I come back. So just like all the stories, you know, he was my patient. I have no other choice but to care for this patient. So that was my story from the bedside. And then I worked at the hospital for a while. So I came to a transitional case, like an adult living area where they have transitional care units. So that was where my teaching caught up with me, because I came from a family of teachers, and I was like, I'm just going to be a nurse. I'm not going to do any teaching. And so every time I'm teaching my family, they keep like, oh, you're a teacher. Why wouldn't you do something? I'm like, no, I'm not. And long story short, I applied to be a clinical instructor, and then there was shortage. So they took me in, and then I started. So when I started, I'm like, you know what? I really need to prove myself. So just like what Danielle said, I have to go back to school. And guess what, everybody? My GPA was not 3.0. I think I was like 2.8 or something. So I was like, how are we going to do this, right? So I started out, applying, but most of the schools are going to take 3.0 and all those stuff. So I got accepted into one that gave me probational admission. Like, I'll prove to you that I got this, because I wanted to do that. So in the course of my education, I got my master's. And whilst I was also going in, I also wanted to have, the experience that I got through nursing school. There were days that I cried because, like, I'm going to clinical in DC, somewhere that I don't even know the place, and I'll get lost. And if I get lost and I'm late for clinical, gosh, like, by the time you get there, as soon as I run in, I'll be the first one that you have to tell me about your patient. What medication are you giving? And all those kind of stuff. I'm like, oh my God. So I always cry to get in there. But then I did get through it. So I was like, okay, I can do this. And I wanted people that come from Africa to come to this place, to have somebody in that position where they can relate to and say, if Rose can get there, I can also do this. So I went through it, and then I got my my master's. So I was like, okay. So whilst I was in the clinical, I got very interested in simulation. So that is where my love for simulation came in, because I'm like, there's nothing like that in my education in back home. So I want to get into that, in a place where you can provide, students with safe environment. They're not going to hurt a patient, and they can learn. Bring it on. So that was where I got that on. And then I started, with a simulation, and then went back for my PhD and, getting. So when it came to work, I've worked in every place. I've worked as a delegating nurse, where I teach, people that are working with individual with developmental disability, where I have to go make sure the medications are all right and all those things. And in that role as well, being the nurse, when I was working as a CNA, I see how it is when we run away when an RN is coming, but I never got that. You know, you go in and people are like, so you're the nurse or what, you know, those kind of things. But yet, I went through it. So fast forward to nursing education. I've been there and I wanted to be the person, you know, that people look up to and then do that. However, when I got all my credentials, it's the same thing. I moved from Maryland to Massachusetts just to change my position because the position that I was in, they were like, yeah, you'll be fine. But how can somebody with a PhD stay in a corner and not really, you know, have that influence? So that brought me to Massachusetts. And I've been teaching. It's been good. It's been all right, but I think we could do better. And I came in and I took my students to a clinical place, and then I love the place. So I still work as an administrative nursing supervisor. So when I go in, sometimes I feel the cold shoulders and all those stuff when I come in. Hi, my name is Rose. I'm the supervisor for tonight. Okay. Right. And you feel the reception and all those stuff. And as recently as last weekend, I worked over the weekend and I had issue with some physicians. So it was like, the physician are supposed to talk to me for me to place a patient in the bed. However, that does not go on. Didn't happen. And they were pushing admitting to do that. So long story short, the patient was left in a dark area. Everybody else is gone. And then, so I went in there to get that patient from the ED, how do you call it, supervisor knows me. And I was just like, well, how can we take care of this patient? So whilst I walked in while the physician who was admitting the patient was talking to an ED physician. And then he was like, oh, the nursing supervisor dropped the ball. And then I walked in there, the ED didn't know it was that. I'm like, I'm the nursing supervisor, so who dropped the ball? I mean, like, let's talk about this situation. And he was like, oh, what are you talking about? I was like, well, I came on board. I didn't even know this patient was in the system. Nobody spoke to me. I think if we have that conversation, would have been over this long time ago. But, knowing that who it is, we could have done it, differently. So I think I'm going to end my story right here and then we can continue if there's any question or anything.
Great. So thank you so much. I just kind of want to tie in some of the themes that I've kind of heard from all of us. So kind of like misconceptions about each other, something that Dr. Dua brought to the conversation. And I kind of want to talk about that because Rose talked about that. Dr. Dua talked about this. While you were all working as nurses, did anyone assume that you were a patient care tech or a CNA? Did that happen to you all while you were?
Oh yeah,
nursing?
So I mean, I went to I applied for this job in Boston. I don't want to mention the name of the hospital, very high-end hospital. And I went for the orientation. First day, nurses, all white. The room was all white because it's a very high-end. It's a very well-known hospital. And not much diversity. So I walked in, went over and sat down. Then the nurse educator asked me, this is not the PCA orientation. I'm like, I'm a nurse and I'm in PhD school.
Yeah.
Yeah. Then so it was just, everybody just looked at me and I'm like, oh, gee. I'm like, I'm a nurse and I'm not here for the PCA job. So it is there, it is.
And then, go ahead.
Sorry, Daniel. And then speaking of usually at my per diem job, I don't go usually when school starts. I teach, so I don't go there. And then when somebody else, oh, so Rose, how's school? And then they're like, oh, are you in nursing school? I'm like, no, I teach nursing school. And the good thing this is like I have students who've graduated from, I have students working on the floor. And then anytime they see me, they go, Dr. Rose, and people will be like, what? Because I let my student call me Dr. My name is kind of, I'm like, before you butcher my name, just call me Dr. Yeah. And then I'm like, we're colleagues now. Call me. It's like, nope, we can't do that. So that's awesome.
And then I know we all have very rich stories. Do you guys use your stories to help educate your students? Maybe like how not to treat others? Like how do you use your stories to enhance undergraduate education, nursing education?
With my story, because sometimes when it comes to, the students will always say that, you guys are out to get us, right? And then I go out and explain that it's not, we're here for it. Sometimes, we're here for you. There is not one single faculty that I know that is setting up here to come to get you. We just want to put out the best. And then I put it this way, it's like, we have to sign out and say we did a good job bringing you up as a nurse. So we want the best for you. So nobody is here to do that. I've gone through it. It's not easy. You also, if I'm up here, you can get it. You just have to work hard. So yes.
Yeah, and me too. Same thing as Dr. Rose is saying, but one thing, I think we didn't talk about students, Dr. Rose, because as students, you also have to always prove yourself, my first job at the college I was before, I worked in there nursing predominantly female Caucasian. I'm the only Black guy. And they're like, oh, gee, what is he doing over here? Is he also a student? I'm like, no, I'm your professor today, So I think I think, for me, my the advantage for me is that I teach psychiatric nursing, and in psych, we deal with some of these concepts and some of these issues. So I, at times, use my stories to be able to explain a concept that is very difficult to just grasp in a textbook, per se.
Yeah, and I mean, like as Dr. Dua said, we have to really, you have to always prove, because there are days that I'm teaching and then students are Googling stuff. And, and I'm like, yeah, I said, there's a whole lot of stuff on Google, but we are going by the textbook and what is the evidence base. So this is the only way, because it's like you're being, and then sometimes, if we brought it out, sometimes I am, how do you call it? I was brought up in Africa. I talk and I go like that, like with my accent or with my voice or with my demeanor. And I've been reviewed talking about some people say I need to go back and learn how to be professional. So it's, you can see from the tone, and then sometimes I can just be like, okay, I know where this is coming from, but it is.
Well, thank you all so much. We have some other speakers that I would love to get to, but thank you so much for both of you all for sharing your stories. I really did enjoy. All right, so we have Dr. Is it Brashan? I'm sorry, Brashan?
Breshnahan.
Yeah,
Yes.
Bresnahan.
Brashan, I'm sorry.
No, not at all. It's perfectly fine. I get confused sometimes. I'm like, did I spell that right? Oh, thank you guys for having me. And these stories, you guys' stories were really great. It brings you back to really living that nursing, life. And I can remember I used to show up at work and I'd be like, this is chaos. I mean, the inequities were just incredible. And I'd have a mantra in my voice. I love you all. And I am, there's nothing you can do about it. There's that Tracy Morgan in my voice. In my head all the time. I love you all. There's nothing you can do about it. I can make it through my day. And then at some point, I remember changing my story to, I love you all and I'm going to do something about it. Left to get a nursing education degree and get a policy degree. And now I'm kind of at this point where it's, I love you all and together we can do something about it. So we have this council now, and I've been so fortunate to be able to be involved in it and help run it and get it moving. I see some of our other council folks on the call here, which is awesome support. And the council was kind of set up to bring folks together to help start working on these, pretty massive problems we have in nursing, the crisis we're dealing with. But it's interesting how, when Barack Obama left the White House, he said, you can change any policy, you can pass any law, but if you don't change the culture, you've changed nothing. And I think that's kind of what we're all faced with today. Like, how do we change the faculty pipeline, the student pipeline? How do we do all this stuff it's not just about saying, okay, we're going to make this new policy. We have to come together and really figure out what are all these things hitting here. So we formed 6 committees, and we have a faculty committee, a grants committee. And I want you to, when you're thinking about this, how can you get involved? Like, can you be a member of one of these committees? Could you join something on your hospital board? Could you get, somewhere involved on a task force or something? Because it's when you bring your voice to these kind of things and other meetings that we can actually start changing the culture. I believe that. I mean, it's top down, yes, but it's also this grassroots stuff too. Our faculty committee is really, it's looking at ways to increase the diversity of the faculty pipeline. And what are all the little, what are the 25 things that are stopping this from happening? Why is it that we have an all-white nursing workforce still almost? And I mean, Danielle spoke to those numbers, and I'm sorry, they were 2014 numbers. You're right, they're hard to find, but it hasn't really changed that much. And that's the sad part of it. Even though we've known for a long time, we need to change these things. Our grants committee is looking at, how do we level that playing field for everyone? Because big organizations, they have grant writers, they can get this funding, which means they get to keep doing the same things they're doing forever, right? Are we changing the culture? No. So, with the DOL grant that just came out, we had a group of people come together and brought in a Centria Cares who does all the immigration services and said, let's help them write this grant. Let's put some money into our communities and really change the way that we're looking at nursing. Our workforce capacity group is looking at, how can we really think about equitable resources within every region of our state and not just certain areas getting all the resources. Next slide, please. Yeah, great. So our nursing workforce data committee, I see our lead here on the call, Hannah. They're really focused on looking at supply, education, and demand data, which is really spotty in our state. We have some good demand data that we've been looking at. But interestingly, we are the representative for the National Forum for State Nursing Workforce Centers now. And so we're helping them look at their minimum data sets. What is it that they think each state should be collecting? And we're starting to talk about, how do we add questions to that help us define, even BIPOC and other parts of the workforce that we're not collecting. So then you don't just have to check that box other, and there's states that won't even let you put those questions on the surveys now. They're passing laws to stop that. So, there's a lot of conversation going on with this nationally, and we'll bring that work back to Massachusetts too. Our clinical placements are looking at how can we get out into the community more, have some community type placements rather than just all hospital based right now for the most part. And our student pipeline looking at how can we bring more diversity into nursing. I mean, some of you, Rose was talking about this. I think, if you don't change the language of the testing, a CNA still has to take and test in English. How are we going to change the pipeline? The NCLEX exam is only in English in this country. It's offered in other languages. Our computers speak other languages. But why is it that only a nursing student has to take a test in English? We are systematically stopping our pipeline from being diverse by making things have to stay a certain way. So, that's probably just my opinion, but I still see there's a lot of problems and we need to look at them all. So I encourage you all to get involved. That's really all I wanted to say because I only had like 5 minutes, but the next slide has my contact information. There's 2 events coming up, and I saw Sasha was on the call from the New England Black Nurses Association. And they're having their 46th annual spring conference, April 28th, which should be really exciting to attend. They know how to put on a good conference. And also the ANA Mass is having a conference focused on diversity, equity, inclusion. And it should be more of like a work day event. And that's going to be April 14th. So if you reach out to me, I can send you that information as well. Thank you. Thank you so much.
Great.
Thank
So,
you.
sorry.
Go ahead, Danielle.
I was just going to ask if anyone that has been listening had any questions for any of us.
Hi, my name is Michelle Heatley, and I'm the Deputy Managing Director at Commonwealth Medicine. And I work with Andrea with oversight of the nursing project. And I have nursing council, and I've been a nurse for over 38 years. And I just can't believe that we're still standing here listening to the painful stories that Doctors Rose, Dr. Akwasi said regarding the way leadership manages that kind of, it's actually verbal abuse and violence, a form of workplace violence. And to not even just have a nurse leader go right in and address it and ensure that the staff are comfortable with the, I applaud Rose. She got through her situation and actually got respect from her patient, but we don't always have time to do that. And it's not up to us to decide you have to do that. If it's something you want to do, but as leaders, we really have to start at the beginning. What's okay, what's tolerable, what's not. And I remember that within the last 5 years before I left emergency nursing, where we saw a lot of violence, I met with a nurse and said, this is not okay. We actually had police come, I had the police come and press charges. And she said, no one ever told me this wasn't okay. And I said, well, I'm really sorry, because it's 2021 and someone should have many years ago said this wasn't okay. So I could go on forever. I'm very passionate about that, but it has to start with basic culture and lack of acceptance of that kind of behavior. And I thank you so much for sharing those stories. They're difficult. They're educational.
Thank you so much for your comment. And I do hear what you're saying. And I will tell you from my experience, the most heartbreaking thing after talking to my nurse manager, during the conversation, well, what could you have done differently? I'm like, well, been born white, I guess. I don't know. There's nothing I could have done differently. But the fact that, it was
It's your fault. Yeah.
Yeah, it was punted back on me.
It's not, and it's never
Yeah.
someone's fault.
So at that point, I knew that was not the hospital for me to be working at.
No.
So I did leave. Does anyone else have any more questions or comments that they'd like to include? I know we're approaching 5 o'clock soon.
And one thing, and Daniel, one thing that I would say is that when I came here and I was looking for schools, I decided to just spread my net, so I was applying to most of the schools in the New England, and I think there was a school that called me for an interview, our neighboring state. I wouldn't mention the name, and the interview went on very, very well, and I qualified. But there is something that the faculty told me that I will never forget, and I could empathize with her, but also there are also other sides. She said, Akwasi, you know what? We would love to have you, but most of our clinical site partners are all predominantly white. And I think you have an issue doing clinicals. And it's just got into me, and I could understand why she was saying that, maybe they had many unsuccessful students come through them, and was trying to avoid me going through such an experience also. So
Well, thank you
just
so
like to
much for
say,
sharing.
Hi, I would just like to say thank you. I have enjoyed listening to your stories. Danielle, did we not meet before then? I thought we did once before.
If we met, it would have did you go to a conference in Barcelona a couple of months ago?
No, okay.
Okay.
But I just wanted to say thank you for sharing. I'm always reminded in trying to, get in touch with my own implicit bias at times. The story that I read of Mary Elizabeth Carnegie, who was as you all probably know, a rock star, a Black woman who was a dean and a professor and quite an administrator. And it always dawned on, it still surprises me today that we haven't come much farther from, in the 50s when she was invited to speak at a professional organization because she had developed a staffing formula that was quite lucrative and the nurses stayed. And so she was invited to a professional organization to present her model. She was able to speak, but when lunch came, she wasn't able to sit at the table. And I mean, that to me just how can you do that? How can you be like that? And we really need to be so much more graceful and accommodating. And I'm looking for ways in which we can certainly diversify nursing. And as a white woman for many, many years, I didn't even realize that nursing was all white. And it was an astute doctoral professor that taught me that this is what's indeed happening. And ever since then, every day, I try to, I love these stories. I thank you. I just wish I had more actions that I could take. And I'm learning. So keep it coming. Thank you.
Thank you so much. And to speak to what you're saying, I think having a lot of different pipelines to nursing, like I was speaking about, like the bridge programs, the master's entry, a lot of actual universities are doing these really amazing programs where they're trying to find kind of people from underrepresented populations and holding almost like summer camps to even expose them for nursing, because a lot of people think that that's so foreign. Like I could never be a nurse because I'm from this area, or no one in my family is a nurse. I can't be a nurse. So I'm really happy to see the emergence of these sort of like step programs into nursing. It's very encouraging.
I love it. You remind me of something I wanted to work on a long time ago. So let's get started.
Yes,
Excellent.
definitely. You let me know. I'm ready.
Okay, bye.
Thank
So,
you.
thank you so much. I put in the chat, there is a toolkit for addressing racism in nursing and healthcare that you may find helpful. But I want to thank all of our panelists and everybody who has stayed through at well after the time. So thank you so much. We really, really, really appreciate your stories, and have a good evening.
Thank you.